A few tips that I've come up with from over the years and that are, again, well established in the literature are as follows on this slide. For older patients, you do have to allow extra time. Their brains, and as I turned 50 myself recently, and I understand it firsthand that the brain just doesn't work as fast. I can't listen as fast as my 12-year-old can talk. I can't think that fast. And it's even more true for patients who are in their 70s, certainly 80s, and more in the geriatric age range. And so we have to allow extra time. Now that's hard, because every other force that is acting upon us as doctors is telling us to speed up and do it faster, see more patients, and do it quicker and more efficiently. And some things just take time. It's like a fine wine. You can't rush it. And so you have to the best of your ability, allow extra time for older patients. I also think it's important to avoid distractions. And we all know the story or heard the story of the doctor who was called out of the exam room 2, 3, 4 times during a doctor-patient interaction. Usually, doctors are interrupted for good reasons. They're receiving a return phone call from someone who's hard to reach. There's some emergency. There's some issue that came up. So there are always good excuses. But that patient, when you're in that exam room with that patient and that door closes, boy, I think that is just a very special and sacrosanct relationship, and it shouldn't be interrupted, no matter what's going on. And I often tell my assistant, my secretary, that when that exam room door is closed, whatever it is that you want to interrupt me for can wait and needs to wait. Even if it's the nanny, even if it's one of my children calling, unless they're bleeding actively, don't knock on that door. And I mean bleeding a lot. Don't knock on that door. And I really try to respect that, because the patient feels that whatever's going on outside that exam room really is external to the patient. And you really, whatever is going on in the life of the doctor, the patient doesn't care about. And rightfully so, rightfully so. I think it's important to sit face to face with the patient and not to stand. Now that can be difficult sometimes in crowded small examination rooms where there aren't enough chairs, but these are things that are fairly easy to fix. But I'll sit down, and I even have the habit of making my stool a little bit lower down than the patient's chair, the patient's exam table where she or he is sitting, so that I'm almost looking up at the patient. And there's something about that, and I don't have science for this, but there's something about that seems to re-empower the patient, make him or her feel in just a little bit more control. And it certainly is no threat to my authority as a physician or as an authority figure, but to give the patient that little height advantage over the doctor when sitting face to face, I think there is some value in that nonverbal communication. Eye contact is critical. All the studies that have been done show that doctors who make good eye contact with patients are ones who have better rapport with patients, better communication. If patients want to see, they want to look into your eyes. When a patient is deciding whether to have surgery, for example, for a bladder or prostate, kidney cancer, and seeing me in the office, and in Los Angeles we live in a very competitive market, so whatever experience I may have as a professor, there are 13 other doctors that the patient is interviewing to perform the same surgery, so I'm constantly on trial and being prepared like a taste test of 3 different soft drinks. And the patient has no way of comparing my technical ability to that of my colleague down the street. But what he or she does is to look into my eyes, and patients use whatever skill set they have in their own human regions. And that's, from eyes to eye. Eyes are a reflection of the soul, it's said, and patients want someone who really has got a good soul. So I try to look at the patient face to face, whether it's good news or whether it's bad news or whether it's just educational. And then the other thing is listening. And again, this may seem like self-evident advice, but listening is of such critical importance. And the studies that have been done show that patients who consider their rapport, their relationship with the doctor to be the best, are ones in which the patient is often doing as much of the talking, if not more, during the interaction. And I think what we tend to do as doctors, I certainly am guilty of it myself, is we tend to say something to patients and then we repeat it in different words. And then to fill the empty space, we say it again, a different way. And then we think of another way to say the same thing over and over. And then, if there's too much space in the conversation, we say it again and again. And it just crowds the patient out. and whether you have a lot to say or a little to say, I think that there is value in being parsimonious with the words that we use, really being efficient in the number of words that we use, and in making statements, getting our point across, eliciting reactions from patients, but basically trying to take up less space, less mental, emotional space in the room with the patient to allow the patient to expand and really be driving the encounter. And I think that's the way that you teach patients to be good patients. You know, you don't teach your 16-year-old to drive a car by having her sit next to you in the front seat and talk about what you're doing. You may do that, you know, a little bit, but ultimately she learns to drive by being in the driver's seat. It may be scary to sit there in the passenger seat. You may want to reach over and grab the wheel, and maybe you have to sometimes. But to be able to put the patient back in the driver's seat, I think is incredibly valuable, or at least to feel in the driver's seat is incredibly valuable for helping her or him through an illness. And all these, I believe, are facets of good doctor-patient communication. And then finally, number 6, really is a reflection of the first 5, is to give patients an adequate opportunity to ask questions and to express themselves. In Los Angeles, it is the habit, many patients today, and I don't know how it is where you practice, to show up with a list of questions that the patients have written out. And any of the websites that patients go to on how to make the doctor visit more efficient will tell the patient to write out on a list of questions, write out on a paper a list of questions that they want to get answered. I know how I feel many times as I see a patient reaching into the front pocket and pulling out that list, and they unfold it and keep unfolding it until it's, you know, really huge, and think, oh boy, I'm going to be late today. And yet, if we assume that every patient has a list like that, either in the front pocket or in the mind, and we try to keep our remarks more limited and allow the patient space for that, they will fill that space. They will fill that extra space. So whether you have 9 minutes for an interaction or whether you have 90 minutes for an interaction with the patient, I feel it's important to take up as little space as you physically and mentally and emotionally possibly can to allow the patient to take up the rest. In general, patients like themselves and they want to hear themselves talk, even though you're the one with the information. And the more they talk, the more they feel they were heard, and the more they feel they're heard, the more they feel you're listening. You might not be listening, but the more they feel they are listening. So it's incredibly important, and I teach this to our medical students here today, to be particularly attentive to that and not to be under the desk with the BlackBerry or the cell phone or all the many other distractions that we have. Next slide, please. I think it's important to speak slowly and clearly so that patients understand. Now, I don't want to speak down to patients, and certainly many of them have advanced education, and they don't want to be spoken down to, but I know that when I went to get my eye checked a couple of years ago because I saw something floating in my eye, the ophthalmologist explained it to me, assuming that I had advanced knowledge of ophthalmology, just because I'm a faculty member at the same medical school, and chattered on with me in ophthalmologic language that I hadn't even heard since medical school, never mind understand now. I think it's safe to assume that when we're talking to patients, most of the terms that we use, they don't understand. And so I think it's important to speak slowly with patients, to build in pauses, to allow them to interrupt us, even though as physicians, we tend to be the more alpha types of people, and we don't want to be interrupted. I think we have to learn to allow ourselves to be interrupted. We have to use short, simple sentences, simpler words. And I'm not talking about assuming a 5th grade education, but I think that we tend in medicine to assume a much higher level of health literacy than patients actually have. I think it's important to stick to one topic at a time and to be organized. One of the things that people often say about physicians is that we are organized. Now, that certainly is not true for everyone, but it helps to be organized in the information that we are relaying to patients so that they, in turn, can have a better and more organized understanding of the information. I think it's a good habit to write down basic instructions, to write down basic care plans. And I'll take out my prescription pad at the end of a visit and not write a prescription necessarily, but I'll write out what our plan is. I'll write the name of the disease. You have Gleason 3+4 adenocarcinoma, stage T2, or whatever the medical is, so the patient can go back and look it up online, or when they get home, the wife's going to want to know, or the daughter, in another city is going to want to know, what did the doctor say? And, it's nice to give the patient some cheat sheets, some notes to go on, to write down the name of the disease and to say options, surgery, radiation, chemotherapy, next steps, bone scan, CAT scan, then follow up with doctor, just the most basic outline. Electronic health records will make this easier, but it's still pretty easy to write it out in neat handwriting on a piece of paper. The use of charts and models and pictures is extraordinarily valuable. There are many free, I have on my iPad that I'm talking to you through now, a free application that I found online that has some standardized pictures, some diagrams of the male and female pelvis. Because I'm constantly using the white paper that's on the exam table to draw pictures for the patient of their prostate or of their bladder or of their kidney and describe where the stone is or where the tumor is or what we're going to cut. And for patients to be able to take that home is valuable. I found this application online for free that I can use my iPad, and I make a nice picture and I draw with pretty colored lines exactly what I want the patient to know. And then, with the click of a button, I can email that document to the patient, and it's all very simple. And so, I would encourage you to look online in the app stores and the app markets for these kind of things. There are wonderful, wonderful tools that are available today that really, really do, I think, enhance the practice of medicine. And then I pause frequently during a consultation or during a visit with a patient where we're making decisions and summarize where we're at to this point. Pause at the end of a paragraph, almost like you're writing a textbook chapter, for a medical student, and summarize where we're at. Patients really, really appreciate that because they're just not up for having a full-on lecture like you go to in medical school for that short 40 minutes or 30 minutes that you might have with them. Next slide, please. This is next to my last